Let's take a look now at Chapter 7, which is dental x-ray film. Let's take a look at the learning objectives for this chapter. We're going to define the terms that are associated with dental x-ray film. We're going to describe film composition and latent image formation. We're going to talk about the different types of x-ray film that can be used in dentistry. And we're going to define the difference between intraoral film and extraoral film, how they're packaged, how they're placed in the mouth. We're going to identify the different types and sizes of intraoral film that can be used. We're going to discuss speed film. That's very important. The faster speed film we have, the less radiation we have to deliver to the patient. We're going to define extraoral film and describe how it is packaged. And we're going to discuss the differences between intraoral film, extraoral film, and identify the types of extraoral film available. Lastly, we will describe the use of intensifying screens and cassettes. That will be used only for extraoral film. We're going to briefly talk about duplicating film, which is not used in dentistry very much anymore. And then we will discuss how to properly store our film and protect it from what we call backscatter radiation, which can cause the film to fog, and when we take a x-ray with that film and process it, we get a very blurry looking film. Let's talk now about the dental x-ray film, the composition of the film, and the latent image. Dental x-ray film is just a version of photographic film that has been altered to capture an image or a likeness. So it serves as a recording medium. An image is just a picture or likeness of the object, and in this case it will be the tooth, the supporting bone, and surrounding structures. And the receptor is just something that responds to a stimulus. So our film is our receptor. It has special emulsions that capture an image, and the image is stored on the film. We call it a latent image because when the film is exposed, we don't automatically see an image. We see it later after we've processed the film. So the latent image is just a pattern of stored energy on a film that has been exposed to radiation. The x-ray film itself is made up of 4 component parts. We have a film base, we have an adhesive layer, an emulsion layer, and a protective layer. And we're going to talk about each one of these. This is our film packet. This is a number size 2 film. This is a standard size film that is used for adults. It can be used anywhere in the mouth for molar teeth, anterior teeth. We can use it for what we call a periapical. We can use it for a bite wing, and we're going to discuss those a little bit later. But I want you to see the film. This is what we call the white side, is what we call the tube side. Remember, we talked in the last lecture about the x-ray machine, how it had the component parts, the exposure, the control panel, the extension arm, the tube head, and the position indicating device. When this film is in our holder and it's inside of the patient's mouth, the PID always is facing the white side of the film. The other side has 2 different colors. It has a little flap here. If I peel it open, I can pull my film out. It's surrounded by lead foil that we're going to talk about in just a second. It's also surrounded by a black paper wrapper, and this is our actual film. This is the base film, and it is coated on both sides with emulsion, an adhesive layer, and a protective layer, and we're going to talk about each one of those. This is just a diagram showing you the different parts that we just talked about for the film. This is the film base itself. This is a plastic 0.2 millimeters in thickness or 200 microns. It is coated on both sides by this thin layer of adhesive. The adhesive is similar to a glue. And then what happens is that glue holds the next layer, which is the emulsion. The emulsion goes on both sides just like the adhesive layer does. The adhesive layer helps the emulsion to disperse evenly across the film. We're going to talk about in just a minute that this emulsion has silver halide crystals in it. Those silver halide crystals are what store the radiation to produce that latent image. What the adhesive does is keep them evenly spread across the film, because without the adhesive layer, all the emulsion may slide to one side of the film and we won't be able to have a picture across the whole film. On top of that, on both sides, is the protective layer. We're going to talk about that in a little more detail too. The protective layer just holds the emulsion and protects it from processing chemicals, from any type of damage that could occur while the film is inside the patient's mouth or while it's undergoing its developing process. Here's a closer look at the film base. We just said that it is a 0.2 millimeter thick piece of polyester plastic. It provides the strength and stable support for that delicate emulsion that is going to capture that latent image. When the film is fresh, it will have this slight bluish green tint. So film actually has an expiration date. There's a correct way to store it to ensure that the film is going to stay fresh and that you get the best image that's possible. Here we're just giving an example of the adhesive layer. We can see that the adhesive layer is this very thin line, and we said it is a glue-like substance that holds the emulsion to the base to keep it from sliding around. And we also have the emulsion on both sides, just like we do the protective layer. We've talked a lot about the film emulsion. The film emulsion is very delicate. It's a homogeneous coating with a mixture of gelatin and silver halide crystals that are attached to both sides of the film. The gelatin is just used to suspend and disperse the silver halide crystals over the complete base of the film. The silver halide crystals we've talked about are what actually absorb the radiation to produce that latent image. And here again, we're looking at the same diagram. Here is our film emulsion. And of course, it is also on both sides of the film. And lastly, we have the protective layer. It's going to be on both sides of the film as well. It is also a very thin coating that covers over the top of the emulsion, like we talked about, to protect it from damage and protect it throughout the processing procedure. Now we're going to discuss the latent image formation. The silver halide crystals contain various levels of stored energy depending on the density of the objects in the area exposed. The stored energy forms a pattern known as the latent image, and of course we've talked about that latent image cannot be seen until chemical processing is applied to the film so that we can see a visual image. Let's continue talking about the latent image formation. When the X-ray photons strike the emulsion of the film, remember we said the emulsion of the film is what contains the silver crystals and the bromide crystals. So those are exposed to the X-ray photons. What happens is some of those are energized and some are not. It depends on the density of the object that the radiation is hitting. Let's give an example. Say, for instance, there's a tooth, and the tooth has a silver filling, or what we call an amalgam filling. So what happens is the X-ray photons cannot penetrate that silver or amalgam filling. So what happens is the part of the film that is behind that tooth, that area does not get energized. So the silver and halide crystals don't store a latent image there. So when that X-ray film is processed, that part of the film will look white. So let's take a closer look at this. It says the crystals that are exposed are ionized, and the silver bromide atoms are separated. What happens is when the X-ray photons hit that emulsion, the silver and the bromide give up an electron. Also on that film emulsion is what we call sensitivity specs. The sensitivity spec is positive. So when the silver or the bromide release that negative electron, opposites attract. So the negative electron finds its way to bond with the sensitivity spec, which is positive. When the positive and the negative meet, that sensitivity spec now becomes neutral. It has no charge. The positive and the negative cancel each other out. And that is where the latent image is stored. This is just a diagram showing you what we just talked about. This area here is the emulsion on the film. And we said that in this emulsion we have silver ions and we have bromide ions. They're dispersed in this lattice type structure. We also said that there was a sensitivity spec within this emulsion. So what happens, what we just said is an X-ray photon comes in and it hits either the Ag is silver, Br is bromide. It hits one of these atoms, and what happens is it gives off this negative electron. Well, we said the sensitivity side is positive, so this negative electron is now attracted to the sensitivity spec. Once the negative and the positive meet, then we have a neutral silver ion, and that is where the latent image is stored. We have three different types of dental X-ray film. We have the intraoral. We've talked about that. That's the film that goes inside of the patient's mouth. We've talked about the extraoral, which is the film that goes outside of the patient's mouth, such as in the panoramic machine that we looked at in Chapter 6. And we also have duplicating film. The main difference between duplicating film and our intraoral film is how we have emulsion, adhesive layer, and protective layer on both sides of the film. Duplicating film only has emulsion, the protective layer, and the adhesion on one side of the film. This is just an example of our intraoral film, and we've said many times before that it's placed inside the mouth and it's used to examine teeth and the supporting structures, which would be the bone level around the teeth. This is just an example of how intraoral film is packaged. The packaging is used to help protect the film from light and moisture. It can be available depending on which type that you want to purchase. There can be 25 film, 100, 150 film in each box. Each box is labeled with the type of film, the speed film, the size of the film, the number of films per packet. We can have 2 film in one packet, or what we call a single packet of film. It has an expiration date. It has the manufacturer's information. So there's a lot of information here on this box. We can see on the side that it's a number 2 size film, which I said before is our standard size film for adults. Let's talk a little bit about the parts of the intraoral film packet itself. We have the actual X-ray film. We have a black paper film wrapper. We have a lead foil, and we have the outer package wrapping. So this is our X-ray film. We've talked about that. That's that 0.2 millimeter plastic base that holds the emulsion, the protective layer. Then we also have a black paper wrapper. This covers the film on both sides. We have a lead foil, and then we have the outer packaging itself. We're going to talk about each one of these parts. Let's talk a little bit about the X-ray film. We've talked about inside of that packet, we can have either a single film base, or we can have 2 film bases. The reason we would have 2 film bases is if we want a duplicate X-ray, because when we take have 2 film in one packet, we get the exact same image with the same quality. So lots of times when we have to duplicate a film or make a copy of a film, we don't get the same quality as the original. So that's why lots of times an office will use duplicate film. They can keep one copy for themselves that is high quality, and they can send a copy with the patient. For instance, if the patient is being referred to see a specialist, they can take an X-ray that is the exact same quality so that it will be diagnostic for the next dentist to look at. The X-ray film itself, of course, is covered with the emulsion. It also has what's called an identification dot on it. It's like a little bump right here, and it's located on the tube side of the film packet, which is the white side. Here's our intraoral film through here. And then we would have the black paper wrapper completely around the film. And then we're going to have a lead foil. What happens is the X-ray photons come from this direction. They hit the film. They keep passing through. And we don't want X-rays to come in one side of the patient's face, travel all the way through, and come out on the other side. So what happens is behind this film is this lead foil. And what it does is it helps prevent the radiation from traveling on through. That's why we place a lead apron on our patients, so that the radiation doesn't penetrate anywhere in the chest area. We'll also put a thyroid collar that has lead, that is lead lined. That way we contain that radiation to only the spot that we're trying to get an image of. Here is the paper film wrapper. It's just a kind of like a construction type weight paper, but it is black. It covers the film front and back. This is our black paper wrapper, and you can see the film sits inside of it, and it completely encloses the film. So this protects the film also from light, because the emulsion on the film is very sensitive to white light. So if any white light gets on it, it will ruin the film, and we're not able to capture an image. We're going to talk about the lead foil. Remember, we just talked about the lead foil. The lead foil is located behind the black paper wrapper, and we talked about when it's in the mouth, The white side is what faces the tube head. The radiation strikes the white outer vinyl wrapping first. It moves through the black paper. It exposes the film, and then the lead foil we talked about helps to contain the radiation or stop what we call secondary or backscatter radiation. If we don't have something to help contain it, then the radiation keeps traveling through. So we don't want that. And if you will notice on this lead foil, you see this little pattern here. Lots of times, the old-timey term, we called it tire tracks, because it looks kind of like tire tracks that a car would leave driving through the mud. So what happens is this pattern is on each lead foil. And like I said, what happens is we should always expose this white part to our tube head. But sometimes we may get in a hurry, and what might happen is we expose it backwards. So instead of seeing this white part, we see the two-tone part. Well, if that happens, what that means is when we place our PID up, when we place our PID up to this film, it's going to hit the lead foil first instead of hitting the film first. Well, when that happens, remember, we're saying we're capturing an image or a likeness of whatever we're trying to take. So since this tire track is on the lead foil, we will also see it on the x-ray, and it's very faint, but you can see it here. And remember what I said, this lead foil helps prevent the x-ray beams from traveling farther than we want them to go. So since it's harder for the x-ray beam to penetrate this lead foil, we have an x-ray that is very light, or it has what we call film fog on it. It looks kind of foggy, like looking out your window when there's a lot of fog outside after it's rained. But this pattern that we see here, we call a herringbone pattern. And this is just an error that was caused by whoever took the x-ray. Instead of having the white part of the film packet face the tube head, they had the two-tone colors, or we had what's called the label side of the film facing the PID. Let's talk a little bit now about the outer vinyl package wrapping. It's a very soft vinyl so that when it's placed inside of the patient's mouth, it doesn't scratch or cut the cheek or the tongue. But it's used to seal all the component parts inside. It prevents the film from moisture and from light. We don't want the film to get wet when it's inside of the patient's mouth. And of course, we've already talked about the white side is the tube side. That's the side that needs to face the PID when we expose the x-ray. It also has a little identification dot that's in one of the little corners. The identification dot is just a little bump that's on the film, and we'll learn as we go through that identification dot will help us mount our film. The way that dot is placed will let us know if that particular x-ray should be on the right side of the patient's face or the left side of the patient's face. And we'll talk a little bit more about the identification dot when we start learning how to mount film. The thing that you need to know right now about the identification dot on the film, the identification dot will always go on our bite block holders. The identification dot always goes what we call dot in the slot. So the identification dot always goes towards the bottom of the film holder. The label side of the film is your two-tone, two colors. It contains the little flap to peel up the x-ray and take all the component parts out. The lead foil is disposed of, but it has to be disposed of in a sealed container because since it's a lead, it's considered a hazardous waste. The black paper can go directly in the trash. When we're done with the outer vinyl wrapping, it can go in the trash. And of course, we'll process the film and keep that for our x-ray. But the label side also has a lot of other information. Depending on the color, if it's white and purple, there's only one film base inside. If it's white and tan, there's 2 film bases inside. It also tells you what speed the film is. Remember, we talked back in chapter 6 that F-speed film is the fastest speed film. And we like to use faster speeds film because it takes less radiation to the patient to get a good x-ray. It also will tell you, there's a little spot on here that tells you, if you look closely, turn the film around, don't expose it to this side, expose to the opposite side, which we know we should be exposing our film on the white side. So it just gives us a lot of information. It gives you the manufacturer's name on the film. So, but for us, we need to always remember the white side is the tube side. There's a little diagram on page 64 in your textbook, and it says always make sure that the white is in sight. So if this is our Amen ring, when this is the way it should appear, so that the PID is facing this way. If when you look through the ring and you see 2 colors, you have your film backwards, and this is what we talked about. What will happen is the radiation will hit the lead foil first, and you'll get that film fog or that herringbone pattern on your film. This is just a picture of the outer vinyl packet, and this is what we just talked about. This is the label side. It's 2 colored. This is the little flap that we can use to peel back. Down here is the name of the manufacturer, Kodak. It's single film. It's kind of hard to see, but you can see the picture in the textbook up here. It would tell you place opposite side towards the PID. So we know that we don't expose this side of the film. Now we're just going to talk about the different types of intraoral film. We have a periapical film, a bite wing film, and an occlusal film. So let's look at each of these. This is an example of a periapical film. Periapical, peri means around, and apical meaning to the apex or to the end of the tooth's root. So when we take a periapical, we're going to see the crown, we're going to see all of the root, we're going to see supporting bone, and we will actually see about 2 to 3 millimeters of bone below the end of the root. With this one, we can use it to diagnose bone loss around the teeth, which would be a patient that may be having periodontal disease. We can diagnose abscesses of the teeth. We can diagnose cavities. So a periapical is going to be a picture of the entire tooth. What we call the crown, the part that you could see in the mouth, all the way down to what we call the apex, the end of the root. This is what we call a bite wing x-ray. It's taken usually with the same size film, a number 2 size film. Remember, we talked in our other chapter 6 that there are different type holders for different type x-rays. Usually when we take the periapicals, we're going to wind up using the blue, which will be for anterior teeth, or we will use the yellow, which would be for posterior teeth. When we take a bite wing, we'll use the red Amen ring. And what the bite wing does is, just like a minute ago we looked at the periapical, and the periapical took a picture of the entire tooth in one arch, meaning either a complete upper tooth or a complete lower tooth. The bite wing film is different. It's used to examine just the crowns and a small portion of the supporting bone that goes around the tooth. And what we're looking for, we can see upper or maxillary teeth, crowns, and we can see lower teeth or mandibular teeth on one film. What we're looking for here is not so much what's going on at the apex or the tip of the root, but we're looking at what's going on right here in these what we call interproximal spaces. Interproximal are spaces that are touching each other. So since we can't see through these with the naked eye, we use our x-ray to catch what we're basically looking for is any decay in these areas. And what you see here to the left of your screen is a number 2 size film, and this is what we call the bite wing part because it goes inside the patient's mouth and the patients bite their top and bottom teeth on this little tab. You can have bite wing film that you can purchase that already has the tab on it, or you can purchase little tabs that you can stick on the film. This just kind of bends down. Then it has 2 little wings. It attaches to the front of the film. So now what happens is the patients, this is their top teeth, bottom teeth. They bite on it to hold it steady in the mouth because remember we said we don't want film moving around because we'll get a blurry image. So they bite here. This would be what we would line the PID up to, and then we would expose the film, and we would get crowns of the maxillary teeth and the mandibular teeth on one x-ray. Occlusal film is the largest size of all intraoral film. It's used to examine large areas of either the maxillary arch or the mandibular arch. The example that you have here is actually the mandibular arch. These are taken lots of times maybe when there's a foreign object that they're looking for to locate, to find where it is. The foreign object might be the hygienist was doing a cleaning on a patient and maybe the tip of an instrument broke off and they're trying to locate where it actually is in the mouth, or maybe the doctor's doing a root canal and a file breaks off inside of the tooth and finds its way outside into the surrounding bone. So, or sometimes patients can't tolerate another type of intraoral film, and so we can use an occlusal film, but it's mainly used just when you want to see a large area on one film, because when we take the normal size number 2 film, we can usually get 2 or 3 teeth on that one film, whereas this gives just about every single tooth in the arch. Let's talk about the sizes of our intraoral film. Intraoral film comes in 5 sizes. We have a 0, we have a 1, we have a 2, we have a 3, and we have a 4. Periapicals on adults are usually a size 2 film. Bite wings on an adult are usually a size 2 film. We talked a little bit a minute ago about the occlusal film. It is a size 4 film, and we have a size 3 film that is used for bite wings, but it's not used in dentistry very often anymore. So this here is a chart of regular film, size 0, size 1, 2, 3, and 4. In our clinic, we're going to be using the phosphor plates. We've mentioned that before. The phosphor plates come in the exact same size as the intraoral film. We have a 0, a 1, a 2, a 3, and a 4. So they're the exact same size. On small children, we use the size 0 film. A size 1 film is also used for lots of times what we call a mixed dentition, when a child may have some permanent teeth, but they still have some primary or baby teeth, and the size 2 film is too big for their mouth. Also, a size 1 film can be used in adults to take pictures of the anterior teeth. Sometimes you'll have an adult who will have a very narrow or shallow palate, and the size 2 film is too large to fit comfortably in their mouth. In that case, we would use the number 1 size film for adults on anterior teeth only, not on posterior teeth. We've mentioned many times that the standard size film is the number 2, and it is generally used throughout the mouth on adults. It is used for bite wings, and it's used for periapical, and it's used in the anterior region and the posterior region. Let's talk a second about the sizes of the bite wing film. We use the size 0 again for small children in the posterior region. We use size 2 for the posterior teeth in older children and adults. The number 3 film we mentioned a minute ago we don't use in dentistry very much. It is longer and narrower than the standard size 2 film, and it specifically was made just to take bite wings. We don't use that film very much anymore because what happens is when we usually take bite wings, we take 2 bite wings on each side. We put molars on one exposure and premolars on the next exposure, and we do the same thing on the other side of the mouth. So we use 2 number 2 size film. Well, the number 3 film was invented so that you could put molars and premolars on one film. That way you would only have to take one x-ray on the patient's right side and one x-ray on the patient's left side. But what happens is, with that film being so long, you get a lot of overlapping, or the contacts in those interproximal areas. We can't get the x-ray beam to penetrate through because there's a curvature of the arch, and that film doesn't allow for the x-ray beam to pass cleanly through the contact areas of the teeth. So when that happens, we get an overlapping, and I can't tell where one tooth starts and the other tooth ends. So if my primary goal is to be able to see in those interproximal areas so that I can detect if there's any decay there, with them overlapped, I can't see. So we no longer use the number 3 size film. We talked about the occlusal film. That's our size 4, and we use it to examine those large areas of the maxilla, the upper teeth, or the mandible, the lower teeth. It's almost 4 times the size of a standard number 2 film. Let's talk about intraoral speed, the speed of the film. The speed of the film is going to determine how much radiation is going to be needed to produce a diagnostic quality radiograph. So what's going to determine how fast the speed film is going to be the size of the silver halide crystals on the emulsion. The larger the silver halide crystals, the faster speed film it will be, and the less radiation that you will have to expose the patient to. The other thing is the thickness of the emulsion. How many silver and bromide crystals are on that emulsion? And also on the film itself, there's special radiosensitive dyes that help to energize that film with the least amount of radiation possible. So a fast speed film requires less radiation, and that of course is our goal, because whenever we deliver radiation to a patient in any form or type, it has the possibility that it can do destruction at the cellular level. So we always want to make sure that we give the least amount of radiation in order to achieve the best x-ray that we can. Intraoral film is given a rating depending on how fast they soak up that radiation. A is the slowest speed film available. F is the fastest. Only D speed, E speed, and F speed film are used for intraoral radiography. We use F speed film because that is the one that requires less radiation to the patient. The F speed film reduces the radiation dose to the patient, but it also provides a radiograph which is has varying levels of contrast. which means we can see different shades of gray. The bone shows as one color. The pulp of the tooth can show as another color. So we can distinguish pulp from enamel, enamel from cementum, bone from enamel. So we have a good contrast of what we're looking at on the x-ray. Now we're going to talk for just a minute about our extraoral film. Remember, we said that's placed outside of the patient's mouth during exposure. We saw some pictures of some panoramic machines in chapter 6. So they're used to examine large areas of the teeth and jaw. The x-ray that you see here on the right side of the screen, this is a panoramic x-ray. It's used to examine wide areas of both upper and lower jaws. We can see the temporomandibular joint. We can see nasal septum. We can see sinuses. We can see the orbits of the eye. We can see the ramus of the mandible. We can see developing teeth. Here's a little tooth bud for a wisdom tooth. This gives us a lot of information about what's going on in the patient's mouth. They're primarily used in oral surgery. They're used by orthodontists for growth patterns for children, to see developing teeth, to see if there's any missing teeth. The x-ray that is on the left of your screen is what we call a cephalometric x-ray. And you can see this is the panoramic is a full facial looking from the front, like if you were standing in front of the patient. The cephalometric is what we call a lateral view. It's like you're looking at the patient with their head turned to the side. The cephalometric gives us a little more, it's a little different type of definition, because on the panoramic we don't see soft tissue structures such as the nose, cheeks, lips. With this one we do. Here you can see the faint outline of the patient's nose. Here we can see lips. Here we can see skin that surrounds the chin. This one we can see orbits of the eye. We also see parts of the spinal column, and then of course we see parts of the skull. So the main difference is this one's a full frontal view. The cephalometric is a profile view, and we can also see soft tissue structures with that. Which one the dentist needs is dependent on what the patient needs. But we do get a lot of information from both of these x-rays. Let's talk a little bit about the extraoral film packaging. This is for our panoramic film. It comes in boxes of 50 or 100. They are actually single films inside of the box. They are not covered with the white vinyl outer covering. They don't have a lead foil. They don't have a black paper wrapper. So they come in different sizes depending on which type of machine the dentist has purchased. But what happens is this film is also light sensitive. So this film has to be loaded in a cassette or a vinyl pouch that we'll look at in just a minute. And it has to be loaded in a dark room. If you open this box and say there's 50 film in here, and you do it in white light and not in a dark room under a safe light condition, you will expose all 50 film and ruin all the film that's in this package. So this has to be opened in a dark room, and then the lid put back on the box before the white light is turned back on. There are two types of extraoral film. There is a screen film and a non-screen film, and we're going to look at each one of these. Let's talk about how we get an image on our screen film. Screen film requires the use of a screen inside of a cassette with phosphors for exposure. The film is sensitive to the fluorescent light rather than the direct exposure to the x-rays. What happens is when we have conventional film, the X-rays hit the film, energize the emulsion on the film, and we capture the image. What happens in screen film is the X-rays penetrate through the cassette, they hit the screens that's on both sides of the cassette, and when that happens, it produces a light, and the light is what exposes the film to capture an image. Some screen films are sensitive to blue light and some are sensitive to green light. The best for dentistry is the ones that uses the green light. The blue lights have to have a lot more radiation given to the patient in order to get a radiograph. And of course our goal has always been to give the patient the less amount of radiation as possible. This is an example of our screen film. This is the base of the cassette, which, think about the cassette is opening this way. We have a top and a bottom. This top and bottom has phosphors located on the top and the bottom. And then there's a protective coating layer here that keeps the phosphors on the screen. And then, of course, the film has to be in between the two screens. So what happens is when the X-ray photons penetrate through the cassette, they hit the phosphors start to glow and emit that light. And in our case, we want it to be the green light. And then the green light is what actually makes the film capture that latent image. We talked about the other type of extraoral film is non-screen film. We don't use that in dentistry because it takes a lot more radiation to expose one that doesn't have a screen. The screen actually intensifies that light that is emitted so that we don't have to use as much radiation to get a diagnostic quality radiograph. Now let's look at the intensifying screens so that you can get a better understanding of what they look like, and also the different types of cassettes. Depending on which type of machine the dentist has, the cassette may be metal or it could be a vinyl pouch. It looks kind of like an envelope. So let's take a look at these. The intensifying screen is a device that we just talked about that transfers the X-ray energy into visible light, and then of course that light is what exposes the screen film. And we said that the intensifying screen actually helps to lower the amount of radiation we have to give the patient. The screen film is secured to the cassette. It's on both sides. The intensifying screen is usually a smooth plastic sheet coated with those fluorescent crystals to produce that fluorescent glow. We talked about how the screens are specific to the light that they emit, that there's a blue light that can be emitted. Those come from calcium tungsten screens, and we do not use those in dentistry. We use the rare earth screens that emit the green light because they require less radiation. We've talked about the cassette. The cassette is just used to hold the film stable. The film has to be, it's like a sandwich. The film has to be in the middle, and then the intensifying screens on both sides. The intensifying screen has to be held tight next to the film. There can't be any movement in there. But as far as the cassette goes, we said it can be metal or it can be a vinyl and be more flexible. But the cassette also has to be light tight, regardless of which type it is. If we talked before, if any white light gets on that film, it'll ruin the film. The screens in the cassettes need to be examined to make sure that they're clean. We don't want any debris, dust to get on those screens because it will prevent the screen from directly contacting the film. Also, sometimes the screens in the cassettes have to be replaced if they become scratched or develop a tear. They have to be taken out. We have to maintain that tightness between the film and the two screens. And here we're just looking at some examples of the cassette. This one here that's labeled C is a metal cassette. This is the film, this is the screen, and there's also an identical screen on the bottom of the cassette. The film is put in the middle of the two screens. This screen here is what has the phosphor coating on it. You put the film inside, you close it, the two screens stay in tight contact with this film. These screens are glued into the cassette so they don't come out, they don't move and slide around. Once this is closed, then the X-ray beams penetrate through the cassette. The first thing they hit is this phosphor screen. It throws off our green light, which exposes the film. We have a latent image here, and then we have to undergo the developing process to be able to actually view the radiograph. The example you have here in letter A is a vinyl packet. It's soft. This one is rigid, and this one is more flexible. You're going to get the same kind of image. It just attaches to a different type of machine. Now, the difference between the metal and the vinyl pack is, we just said, the screens are glued in place here. So there's no way that you cannot put the film in the middle. When you use the vinyl packets, the screens are not glued to the front and the back of the packet. So you have to be careful when you put the film in so that you don't put the film in front of a screen or behind one. You have to make sure that we talked about that sandwich. You have to make sure that the screen goes in the middle of both of those intensifying screens. Otherwise, you may have it in front, and then the film is not going to be exposed because the radiation may hit the film first, and there's nothing to energize those screens to emit the light to produce the latent image. Let's talk very briefly about duplicating film, because duplicating film is not really used anymore. We talked early on in this lecture that duplicating film, you do not get the same quality of x-rays as the original. And now, since we do digital x-rays and indirect digitals, we can turn our film into a JPEG file and send it anywhere it needs to go with the same quality as the original. But we talked earlier, duplicating film is a little bit different from our regular film in the fact that it only has emulsion on one side of it. And the way that it is produced is different too. You have to have a duplicating machine with a white light. So how our processing for this is a little bit different. What happens is the machine has a little white light source about the size of the film. What you do is you put your original x-ray on the little white square, and then you would place the duplicating film on top of that, and then you would close the lid on it. And what happens is you turn on the white light, and the longer the light you leave the light on, the lighter the film is going to be. But what happens is this film is exposed by the white light. So once you have an image captured on the film, then it still has to be processed through the developer. But we talked about before, you never get the same quality as the original. So we don't really duplicate film anymore in this manner. If we did not have digital or indirect digital, the doctor would purchase the film packet with 2 film bases, because that way he does get an exact image. He has 2 of the exact same images. So that works much better than trying to duplicate an x-ray. Duplicating film also comes in different sizes. It also comes in the same sizes because you may need to duplicate a panoramic, you may need to duplicate a cephalometric, so they also come in different sizes. We've already talked about how our film is very sensitive to white light. It is also affected by extreme changes in temperature. If it's too hot or too cold, it can crack the emulsion on the film. If the emulsion cracks, then we can't produce those sensitivity specs to store our latent image. It's also affected by humidity. We said it can also be affected by backscatter radiation, in which case we would have film fog on the film. So film that has not been used should always be kept in a cool and dry place. We want film to be stored in a temperature range of about 50 to 70 degrees Fahrenheit. That way it's not too hot and it's not too cold. We also like for it to be kept in a place where the humidity is between about 30 and 50%. We don't keep unused film in the operatory with us, because what happens is, since we are exposing x-rays in those rooms, the unused film can pick up some of that radiation, and then we'll have film fog. Film also has an expiration date, so you want to make sure it's kind of the first in, first out rule. You don't want to, let your x-ray film expire on you, because then you're going to get an x-ray that's not going to have the shades of gray, the correct contrast that you're looking for. Please, if you have any questions, don't hesitate to email or give me a call. I'll be glad to clarify anything that you may have questions about.